Hi, I'm Dr. Gregg Fonarow, a professor of cardiovascular medicine at UCLA. I direct the Amundsen UCLA Cardiomyopathy Center and have been very involved in heart failure, quality of care, and outcomes research. So I've been involved in a number of heart failure clinical trials and registries. I'll specifically be involved in a comparative effectiveness registry that is sponsored by Novartis and does involve serelaxin, the drug that we'll be discussing. So serelaxin is a recombinant form of relaxin-2. This is a naturally occurring hormone that has vasodilatory and other mechanisms of action. It's actually produced by the body by tissues such as the ovary and prostate and the placenta. It rises very substantially during pregnancy and has a number of biologic effects. More recently, it has been studied as a therapy for acute decompensated heart failure. So there had been an important randomized clinical trial in patients with acute decompensated heart failure called RELAX-AHF that was presented at one of the national meetings and published in The Lancet. And this drug, serelaxin, had then been submitted on the basis of a pilot trial as well as that pivotal trial published in The Lancet for consideration for FDA approval and marketing. And the FDA did recently announce that it offered breakthrough status for this drug in the review process. So we'll get an accelerated review based on the very promising findings that were presented and published. So this was a trial of serelaxin in patients hospitalized with acute decompensated heart failure. These patients had to have a systolic blood pressure above 125 and mild to moderate renal insufficiency. There were two co-primary endpoints that looked at decreases of symptoms of dyspnea measured by two different ways, one a Likert score and one a visual analog scale, and using the area under the curve. There were a variety of other secondary endpoints as well as important safety endpoints, one of which was all-cause mortality in the first 180 days. So one of the key findings was that for the co-primary endpoint of improvement of symptoms of dyspnea using the visual analog scale, there was an improvement for that area under curve that was statistically significant. So over time, after administration of the drug added to standard background therapy versus placebo, patients felt better. By the second co-primary endpoint that looked at specific time points and on a 7-point scale, there were not statistically significant differences. A number of the secondary endpoints, though, did show favorable associations, things by the global scale of symptom improvement. Worsened heart failure was more likely in patients receiving placebo plus standard care versus serelaxin versus standard care. Other endpoints, though, such as rehospitalization for worsened heart failure, renal failure, or death at 60 days did not show a statistically significant difference. So when we look at what is desirable in a drug for acute decompensated heart failure, what is most desirable and that we currently have no therapies that have been demonstrated to achieve would be an improvement in survival of patients. And so that is certainly an outcome that many thought was potentially not even possible for a drug that may be administered just for a few days and the patient is first hospitalized, but is a very impressive finding of the study, one that we would like to see replicated, but certainly has generated the most interest. We recognize, though, that improvement in symptoms is very important, and to have an objective scale in a double-blind, placebo-controlled trial where the patient doesn't know how they're being treated, in which they were assigned to placebo or study drug, and the physician doing the assessment or study coordinator is not aware of that assignment, to detect a difference difference in symptoms is important. Showing stabilization of the underlying disease state, so measures that look at the degree of cardiac injury, renal perfusion, and renal function is measured by creatinine, stretch of the myocardium is measured by BNP. Seeing favorable changes there is also something that we think is complementary to the clinical outcomes. Other components and things that we look towards were length of stay in the hospital, or the need for length of stay in the intensive care unit increased or decreased. In this trial with serelaxin, there were actually statistically significant and clinically relevant decreases in both hospital length of stay and intensive care unit length of stay. So this drug, assuming the outcome data holds up and is replicated, would represent a really important breakthrough in our ability to manage patients with acute decompensated heart failure. Currently, for symptom relief, we have intravenous loop diuretics, which, while they do improve symptoms, leaves these patients hospitalized with heart failure still at high risk for recurrent decompensation, recurrent hospitalization, and mortality rates that approach as high as 15% within the first 30 days. If we had a therapy that became available that made these patients feel better, improve the disease state, but importantly could reduce mortality by up to 37%, this would represent a tremendous breakthrough for the over 1 million patients in the United States that are hospitalized with the primary diagnosis of heart failure, and many, many million more worldwide. We have no current therapy that has been demonstrated to improve survival in these patients, and to have such an important therapy come along that could improve outcomes would really be readily embraced by the clinical community as well as patients.